and obese PCOS also, resistant PCOS, how to treat them without the risk of having OHSS for these patients. We had difficult conceptions, and when we don't have follicles forming, after some time we have them having triplets when they have 3 follicles. So to avoid OHSS and to have a good ovulation for PCOD, I think we have to learn and do more effective work in PCOD. We have Dr. Satyapriya who has taken up the lead in PCOD clinic in A4. So can I have the CV slide of Dr. Nitya? First is Dr. Nitya speaking. Yeah. So Nitya is a consultant at A4 Hospital and Fertility Center. She's a former consultant in Institute of Reproductive Medicine in M. And she was also assistant professor in SRMC, Chennai. She has finished her UG and PG in Ramachandra. She is a member of OXY, FOXY, ISAR, TAPISAR, and IFS. Her special interest on infertility, high-risk obstetrics, and gynec endoscopy. She's going to talk on pathogenesis and basic drug therapy during PCOS with the pathology or pathophysiology of PCOS. And we have next our speaker, Dr. Satyapriya. She has finished her MSOG in Ramachandra, her fellowship in advanced gynec ultrasound in SRMC, and fellowship in reproductive medicine again. So she has spread her area of interest into 2 dimensions, but she's focusing right now mostly on infertility. So over to you both. We are looking at a fruitful discussion. The idea of starting this sessions was to have proactive discussions and telling your own success stories and difficulties in this forum. So please be free to discuss all the issues that you have in the day-to-day practice, so that we can take it up not like any theory class and do a proper discussion among ourselves. Over to you, Dr. Nitya.
Yes, ma'am. Ma'am, I'm audible?
Yes.
Yeah. Okay. Okay. Yeah. Good afternoon, one and all. So, why I chose to present on pathophysiology to practical aspects would be that the pathophysiology, although we've known about a lot of pathophysiology for PCOS, there's still more to be researched about, which I'll be talking about in the next few slides. So when you see the trend of publications in PCOS research, we've seen that in the last 10 years, there's always been an upward trend with an annual growth rate of 15.7%. And prediction of PCOS research future hotspots in 2020, we've seen that it has been about antioxidants, gut microbiota, supplementation, and pathogenesis. So these 4 have topped the list in PCOS. So this paper tells about how in the current analysis, PCOS pathogenesis has become a long-term forefront of the research. Now, going back to the basics, to know about the pathogenesis of PCOS, we'll have to know about the etiology and the pathogenesis, what is our current understanding, the factors involved in the pathogenesis of PCOS, and the perspectives regarding the future potentials. So as we know, this is a very complex structure for PCOS pathophysiology. So let's start it at one point, and then we will gradually see that they are all interlinked. So we know that in PCOS, there is hyperandrogenism. So this can cause ovarian dysfunction with an aberrant follicular growth. Now, this can cause more of preantral and small follicles, leading to more of AMH. So when there's more of AMH in the body, there is altered GnRH pulsatility, which will have an effect on the hypothalamus. And it will also alter the follicular microenvironment. This hyperandrogenism can cause abnormal GnRH pulsations, which can cause increased LH, and this can lead to LH-FSH ratio being altered. Now, again, because of this increased LH and FSH ratio. This can again cause ovarian dysfunction and aberrant follicular growth. Also, this can also lead to dysfunction of the intrinsic theca cells, which will increase the androgens in the theca cells. This hyperandrogenism also causes insulin resistance, which will cause hyperinsulinemia, and this will reduce the glucose uptake and increases the gluconeogenesis. This will increase the hydrolysis by releasing more of free fatty acids, and it will inhibit the sex hormone binding globulin receptors, leading to more of bioactive free testosterone. Now, when this free testosterone is more, it again acts on the insulin and makes it have more resistance. And again, more insulin resistance can cause hyperandrogenism, because there's more androgen synthesis from the adrenals as well. Now, knowing the pathophysiology, where did this start from? Why is there hyperandrogenism? Now, there are various factors which are postulated. Now, coming to the familial aggregation, we've seen that various studies have explained the same. So this particular article from Fertility Sterility in 2016 says that sharing common susceptibility loci between the Chinese and European ancestry suggests that the PCOS may have persisted for more than 50,000 years before the migration of humans out of Africa. So there is a common genetic risk profile across population. And coming for genome-wide association studies, we've seen that there are many receptor polymorphisms, and also unfavorable lifestyle after birth. So it could be phytoestrogens, pesticides, phthalates, or dioxins. It could be the perfumes that we are using, advanced glycated end products. It can be the junk food, and no exercise and addictions. All of these could have been could have contributed to this PCOS. Now, next one that they have postulated is the follicular ER stress. So endoplasmic reticulum is an organelle which is responsible for the folding and assembly of secretory proteins. Now, ER stress is a condition in which the unfolded or the misfolded proteins will accumulate in the ER because of an imbalance in the demand for protein folding and capacity. Now, this hyperandrogenism can cause ovarian fibrosis, follicular growth arrest, accumulation of AGs, altered steroid metabolism, dysregulated COC expansion. Now, there is also prenatal exposure to intrauterine microenvironment of mothers with PCOS. So again, this study, which is based from the Swedish nationwide register-based cohort. Now, daughters born to women with PCOS have 5-fold high risk of PCOS than those born to women without PCOS. Now, here we can see that if the pregnant women had higher serum AMH levels, which will induce the maternal neuroendocrine, which will induce more of testosterone. And the metabolic dysfunction in PCOS can cause hyperinsulinemia in the fetus, which will increase the androgen production in the ovaries. What is the evidence for this excess androgen? Is daughters born to women with PCOS have higher anogenital distance, which is a biomarker of intrauterine exposure to excess androgens. Serum androgen concentration is higher in PCOS pregnant women compared to normal women. Placenta from PCOS women has higher activity of 3-beta hydroxysteroid dehydrogenase and low activity of P450 aromatase. Now, what is the mechanism? The induction of epigenetic changes in fetal somatic or germ cells, or exposure to androgens, or dysbiosis of the gut microbiome. So this is gaining more importance these days. The effects of prenatal exposure of high androgen on the gut microbiome and development of PCOS. In PCOS women, they found that the high intestinal levels of bacteroids and various other microbiome as well. So in this study, they had injected the DHT in utero to the mouse, and they found that so there was altered gut microbiome was identified. So prenatally androgenized offsprings have abnormal gut microbiome, and this is amplified by consumption of certain food and sex steroids after puberty, contributing to PCOS. Now, as we know, these are interlinked: hyperandrogenism, metabolic dysfunction, and dysbiosis of gut microbiome. So now coming to the practical aspects of it. Now, to first diagnose PCOS, now the step one is, now this is postulated in the international evidence of PCOS. Now the step one is, if patient comes with irregular cycles, find out if the patient has any clinical hyperandrogenism. If it is present, the diagnosis is very simple. Now, if there is no clinical hyperandrogenism, then test for biochemical hyperandrogenism. And if that is positive, then we take it as a diagnostic. Now, if the patient has only irregular cycles or hyperandrogenism, then do an ultrasound to see the PCOM morphology. So this is one important practical aspect that we will have to do. So it is always better to calculate the free testosterone, although it is very difficult and we don't get the accurate values. So hence, we do the total testosterone. But although the free testosterone is the best marker. So because it is not available easily, the free androgen index can be used. So how do we calculate is 100 multiplied by total testosterone divided by SHBG will give us the free androgen index. So usually the cutoff can be taken as 6. So, so how do we talk about the success of PCOS women is when there is obesity, the degree of hyperinsulinemia, or the concentration of the circulatory LH. All these three play an important role in the success. Now, before we so PCOS is also a diagnosis of exclusion. So what are the other disorders that we'll have to exclude when patient comes with irregular cycles? Pregnancy, we can do a beta HCG. Ovarian failure, do an FSH. Hypothyroidism, thyroid levels can be checked. Prolactin, hyperprolactinemia, or CAH, 17-OH progesterones. Ovarian tumors, we can check for the total testosterone. Adrenal tumors, DHEAs, Cushing syndrome, serum cortisol, and acromegaly as well. So the key to success is that the patient has to have healthy food, physical activity, stress, sleep, and de-addiction and psychological support is the main key to success. So this has to be implemented to whatever sort of treatment that we are going to do. Let it be an ovulation induction or an IUI or an IVF or an ICSI. This has to be the key, and this has to be we make sure that this has been explained to the patient. So they might just think that we are diagnosed with PCOS and then we're directly going for an IVF. So the success is going to be very simple. So that's not the case. So a 5 to 10% weight loss is mandatory because this will reduce the LH pulse amplitude, androgen production. It reduces the insulin, reduces the extraglandular aromatization, and it will increase the SHBG. Now, coming to the algorithm, so this is put up in the international evidence of PCOS in 2023. So here it clearly states that lifestyle interventions are the key, and the first line pharmacological management would be letrozole to be considered as the first line, clomiphene with metformin or metformin alone, or gonadotropins. The second line management will be gonadotropins or a laparoscopic ovarian surgery, although there are specific conditions where it can be done. Or the third line will be doing other interventions, including IVF. So first, let's talk about the drugs. Dr. Satyapriya will be explaining more in detail about the recent medications which are in use right now, and many trials and many studies we have also been doing in our unit. So, so this is about, this study is done in 2014. So this is between the letrozole and the clomiphene for infertility in PCOS. Now, this shows that Letrozole is better than clomiphene citrate, especially when the BMI is more than 30. And this is a comparative study between 9 ovulation induction therapies in patients with clomiphene citrate resistant PCOS. So this was a meta-analysis. They found that there were three efficient drugs, that is HMG, FSH, or metformin combined with letrozole. Now, if you look at this tabular column, now the pregnancy rate per intention to treat, we found that HMG tops the list, followed by um, metformin with letrozole. And live birth rate, metformin with letrozole tops the list, followed by HMG. Now, ovulation rate per cycle, again, metformin with letrozole, then followed by FSH had good results. Abortion rate per pregnancy, metformin with letrozole had the least abortion rate. So, okay, so why is CC not the first choice? Is that when CC, when given in patients with normal cycles, LH pulse frequency will increase. So this is the frequency that will increase and not the amplitude, suggesting that there's an increase in the hypothalamic GnRH pulse frequency. In women with PCOS who already have a high frequency, CC can cause an increase in the amplitude. Now, when this increases, there will be an increase in the daily plasma secretion of LH and FSH. Now, CC in the absence of estrogen can enhance the FSH stimulation of LH receptors in the granulosa cells, and it also acts as an anti-estrogen on the uterus, cervix, and the vagina. Now, the treatment scheme for oral ovulogens, the lifestyle modification, followed by letrozole, which is the first drug of choice, either a 2.5 or a 5 mg, or a clomiphene citrate can be used 50 to 150 as a maximum dose. Now, if there is ovulation, good. If there is no ovulation, then increase the dose. If the patient is obese, then metformin, or if there's an insulin resistance, metformin can be used. And if again there is no pregnancy, then we'll have to go to further testing and going for a higher treatment modalities. So, like I said, lifestyle modification, and in patients with resistance. So, suppression of LH is important, where we can give a pre-treatment with an OCP or with progesterones. The alternative protocols with CC and letrozole can be used. Dr. Satyapriya will be explaining more about the other protocols which we can use, like stair-step protocol and the chronic low-dose protocol. Dexamethasone does have a good role in patients who are having resistance. Insulin sensitizers like metformin and myoinositols are being used, gonadotropins or LOD. So adding dexamethasone is used to treat PCOS, an adrenal or a mixed adrenal and ovarian hyperandrogenism. Now the dose is 0.25 at night from day 2 to day 11 when patient is undergoing ovarian stimulation. Now this will suppress the DHEAs and preferably used when the serum DHEA levels are more. This is off-label use in ovulation induction, although it is effective as an adjunct to CC in PCOS with resistance. 75% of the times ovulation is there when it is combined with oral ovulation. And 15%, so this study in fertility sterility, which was released in 2002, way back in 2002, itself shows that adding dexamethasone had good results, and even the pregnancy rates were good. Metformin, as we already know, there are various mode of action for metformin. So this study in 2018, now this shows that as metformin was added, in patients who had hyperinsulinemia, metformin did work well and it reduced the insulin levels. Whereas in patients who had normal insulinemia, there was not much statistical significance. And also by giving metformin for at least 3 months, they found that the AMH levels did drop and the AFC levels did drop. Coming to myoinositol, there's various mode of action for this as well. The dose will be 4 gram per day is optimal. Although there are two myoinositol, we have a ionositol. So the ratio has to be 40:1. So make sure the drug that we are using has the combination in 40:1. Now, treatment with the ionositol in anovulatory women with PCOS versus placebo or no treatment, it showed that there was significantly improved ovulation rate, although there was not much difference in the clinical pregnancy rate, and no studies on live birth. And it reduced the androgen levels and decreased the fasting insulin and glucose. And there were no serious side effects. So metformin versus myoinositol and RCT in 2017 both significantly improved the insulin resistance sensitivity and reduced the insulin response. Metformin significantly decreased the BMI and the Ferriman-Galway score, and metformin also decreases the LH. In conclusion, both treatment improved the glycemic index and the insulinemic, but only metformin seems to exert a beneficial effect on the endocrine and clinical features of the syndrome. And coming to laparoscopic ovarian drilling, it is not for all. It's for lean and a high LH concentration have the most favorable prognosis. Although we'll have to keep in mind this will be only a second line when there is a resistance. And this may be used as a first line option when the lap is indicated for any other reason, a myomectomy, or if there is any tubal a tubal factor. But the concerns have to be kept in mind, and this has to be explained to the patient about adhesions and ovarian destruction. So the future perspectives will be lifelong management and keeping in mind the pathophysiology. The future research is about factors inducing development and progression to PCOS after birth, mechanisms underlying the high heritability, biomarkers to identify individuals at high risk during their early life itself. Thank you.
Okay. Thank you, Nitya. Um, shall I share my screen?
Sure.
Yes, ma'am.
Okay. 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 Good evening. Now, Dr. Nitya has spoken about the pathophysiology and pathogenesis of PCO and the basic and conventional management. We'll go a little bit into the practical aspects and recent advances and newer drugs that we've been using for the past some time. Um, So the management of PCO starts right from preconception, where counseling plays a very important role. So the patient has to be the time has to be spent in counseling the patient regarding the adverse effects of weight, the miscarriage rates associated with the weight and associated with the condition itself, live birth rates, and pregnancy complications, and uh, preconception is the right time to optimize the risk factors such as weight, BP, sleep, and nutritional status, and also the right time to start them on nutritional supplementation like folic acid and vitamin D. A lot of research is going into this alternative treatment of PCOS based on traditional and herbal medications and plant-based drugs. This article has summarized the use and benefits of many of the household spices and herbs found in our household. And it will be a good idea to encourage our dietitians to explore these further and give a tailored diet chart to the PCO patients seeking diet plan. And especially it will be useful in patients who come for preconceptional advice for those in the younger age and recent married life. They talk a lot about curcumin, black cumin seeds, cinnamon, spearmint, basil leaves, resveratrol, all these which are commonly found. Mm, so coming to the pharmacological management, ovulation induction, letrozole is the first line pharmacological treatment for ovulation induction in infertility in patients with PCOS. So the traditional protocol has been starting the ovulation induction with the lowest dose of the drug for 5 days and starting anywhere from day 3 to day 5 of menses. And when ovulation is not detected, the patient is followed up 5 to 7 days after the last dose of tablet. And if no ovulation is detected, a withdrawal is usually given with progesterone, and the dose is titrated systematically up from the next cycle until the maximum dose of medication is reached. This stair step protocol eliminates the use of progestin to induce withdrawal bleeding between sequential treatments, thereby decreasing the time to ovulation and indirectly the time taken to achieve pregnancy. Here in this article published in 2019, they've assessed the ovulation rates in stair-step protocol with letrozole versus clomiphene citrate in patients with PCOS. So the purpose was to compare ovulation rates between letrozole and CC using a stair-step protocol to achieve ovulation induction in women with PCOS. This was a retrospective cohort of predominantly Hispanic PCO women of reproductive age who completed ovulation induction, comparing women who underwent letrozole stair-step protocol to those who underwent OI with CC stair-step. All women had diagnosis of PCOS based on the Rotterdam criteria, and for both protocols, sequentially higher doses of letrozole or CC were given 7 days after the last dose if no dominant follicles were seen on ultrasound. The primary outcome was ovulation rate determined by presence of dominant follicle between the two treatment groups. And secondary outcomes included time to ovulation, clinical pregnancy rates, and side effects. The results: 49 PCO patients completed the letrozole stair step cycle, and 43 were in the CC group of patients. And overall demographics were comparable. And ovulation rates with letrozole were equivalent to CC stair step protocol, although the mean time to ovulation was shorter in the letrozole group. So this has been the first study to that had compared the efficacy of the stair-step protocol in PCO using letrozole and CC. And both letrozole and CC can be prescribed in a stair-step fashion. And letrozole was found to be equally efficacious as CC stair-step, and patients achieved comparable rates of ovulation and clinical pregnancy. But the time to ovulation was shorter in the letrozole group. So this was the regimen that they used. They concluded that both can be prescribed in the stair-step fashion, and both are equally efficacious, but the time taken to ovulation is shorter in letrozole group. In this study, they had compared various letrozole regimens for ovulation induction in women with PCOS. Here, the objective was to determine the optimal letrozole regimen for ovulation induction in women with PCOS, and it was a retrospective cohort study in a single center. And total number of 189 ovulation induction cycles in 52 patients were analyzed. The interventions were patients were grouped into four groups for four regimens. The group 1 received 2.5 mg for 5 days, group 2 2.5 mg for 10 days, group 3 5 mg for 5 days, and group 4 5 mg for 10 days. And the primary outcome was ovulation, and secondary outcome included multifollicular development, clinical pregnancy rate. The results found that those who received 5 milligram for either 5 or 10 days, or 2.5 milligram for 10 days achieved ovulation significantly sooner, and multifollicular development was not increased in group 2 2, 3, and 4 as compared with group 1. Group 2 to 4 also demonstrated improved time to pregnancy. They concluded that ovulation rates are improved when starting letrozole at 5 mg per day for 5 days, or 5 mg per day for 10 days, or even 2.5 mg per day for 10 days extended course, as compared with the frequently used 2.5 mg for 5 days. This may shorten the time to ovulation and pregnancy. So the limitations of this study was possibility for selection bias because providers chose the regimen, and heterogeneity in clinical practice. Some patients received rigor in this study, some additional scans, and some preferred spontaneous ovulation and at-home kit testing. And there was heterogeneity in the distribution among the groups also. Group 1 had the maximum number of patients. Group 2 had the lowest number of patients. And that limited the further analysis among group 2, 3, 4. And some patients were also lost to follow up, and the outcomes of these cycles would have been unknown. Coming to gonadotropins, gonadotropins are the second line pharmacological therapy for women with PCOS. They may be indicated for prevention of PCOS and treatment of PCOS.
பெருத்தாங்கம்மா. ஆமாங்க. இல்ல கொஞ்சம்
Am I audible now?
கொஞ்சம் பிரச்சனை இருக்குன்னு போட்டிருக்காங்க. இந்த உங்களோட
Okay.
ஹார்ட்ல
Hello?
கொஞ்சம் மைட்ரல் வேல்ங்கிற வேல் வந்து லூஸா இருக்கு. அதனால அதுல கொஞ்சம் எம்ஆர்னா ரீகர்ஜிடேஷன் இருக்கு, லீக்கேஜ் இருக்கு. நான் வந்து யாரு ஹார்ட் டாக்டர் பார்க்க வைக்கணும், யாரை பார்க்கறதுன்னு சொல்றேன்.
Am I audible? Screen share தான் பண்ணிட்டு இருக்கேன். Your screen sharing. I'm
Okay, your screen sharing.
but
Where
voice.
is the screen?
Hello.
You're audible.
கேக்குதா? ஸ்கிரீன் தெரியுதா? இப்போ தெரியுதா?
Yeah. Now it is. Now it's.
Voice.
Yeah, you're audible.
Gonadotropins. Hello. Hello. Am I audible?
Yes, ma'am.
Okay. I'll continue then. Typically, 7 to 12 days of treatment is required, sometimes longer. Patience is key in this kind of an approach. And once the mature follicle develops, HCG trigger can be given. So they summarized that gonadotropin cycles should be managed by a clinician with the requisite training and experience. The goal is to promote the development of a single mature follicle. Monofollicular development sometimes can be difficult to achieve. Monofollicular development decreases the risk of multiple gestation and OHSS. The risk of multiple gestation and OHSS cannot be completely eliminated with the use of gonadotropins, even if we start with a low dose, and this should be clearly conveyed and counseled to the patient. Gonadotropin should be started at a low dose of 37.5 to 75 international units per day and cautiously increased as needed for monofollicular development. And if more than two follicles, more than 16 develops, cycle cancellation should be considered. Or if 3 or 4 intermediate size follicles develop. Luteal phase support is beneficial following ovulation induction with gonadotropins in women with hypothalamic amenorrhea and may also be beneficial following ovulation induction in women with PCO. I've added some case scenarios, relevant case scenarios after the
ಜಾಯಿನ್ ಆಯ್ತದಿಲ್ಲ
I do LP
ಲಂಬಾರ್ ಪಂಚರ್
had irregular menstrual cycles and usually had this. She was a known case of PCOS, and her treatment history outside included and alleged history of no dominant follicle formation with both oral or gonadotropins. HMG 150 up to 4 doses were given. Her BMI was low, I mean normal. Hirsutism plus, AMH was high, and USG revealed bilateral PCOM. Male factor was normal. Here in our center, we planned ovulation induction and timed relationship in view of recently married and gonadotropin 75 units oral ovulation plus gonadotropin 75 units were given. She developed in the first cycle, she developed multiple follicles and hence the cycle was cancelled. In the second cycle, a lower dosage was planned. So she was started on letrozole followed by low dose FSH, 37.5 international units. And on day 24, she had daily doses. And on day 24, she developed 3 dominant follicles. Because the cycle was a prolonged one and required multiple doses of medications and the cost involved, IUI was planned for her and the patient conceived that cycle. The take home message from this case is that counseling the patient regarding need for prolonged administration of gonadotropins, keeping her previous response in mind, the cost implications, the success rates, and still the possibility of OHSS in multiple pregnancy and the risk of failure, all this put together and along with the patients required from the patient side was important in helping her to conceive. Glucocorticoids in ovulation induction, Dr. Nitya has already covered. I'll just go through some articles and one case scenario. Mrs. A, 30 years, who has been married since 3 years, having irregular menstrual bleeding, a known case of PCO, hirsutism, and subclinical hypothyroidism, was obese, BMI 33.7. Male factor, the husband had borderline diabetes, was on lifestyle and diet measures. The treatment history, outside she had underwent multiple cycles of ovulation induction with oral plus gonadotropins. Ovulation was documented in some cycles, whereas in most cycles she failed to develop a dominant follicle. At A4, investigations were normal. She had borderline sugars and was started on diet and lifestyle measures. In the first cycle, she was started on oral ovulogens and planned for a natural cycle, ovulation induction cycle, and timed intercourse. She developed a dominant follicle but failed to conceive. In the second cycle, she was actually planned for IUI and started on oral ovulogens and gonadotropins. FSH 75 international units, 4 doses were given. But because of her previous history of failing to develop follicles, a dominant follicle, she was also started on Dexa 0.5 mg BD for 10 days from the start of the ovulation inducing agents. She developed 4 dominant follicles in the mid cycle. In view of multifollicular development, the IUI plan was cancelled and advised only natural contact. And in that cycle, patient conceived with a singleton intrauterine pregnancy. Glucocorticoids. This is an article which was released in November 2022, where they assessed the efficacy of adding dexamethasone to letrozole as an ovulation induction agent in infertile patients with and compared them with patients who received only letrozole. So, the approximately 15% of patients may fail to ovulate after receiving letrozole and are considered resistant. This is after they receive the maximum dose of 7.5 mg per day. And the objectives of this study was to assess the efficacy of adding dexamethasone to letrozole for ovulation induction in women with letrozole resistant PCOS. The methods, this was a cross-sectional study, 23 infertile women with letrozole resistant PCOS who underwent 36 total cycles of ovulation induction. The letrozole resistant were defined when no dominant follicle was identified on scan following maximum dose of letrozole. These patients subsequently received 5 additional days of letrozole 7.5 mg along with the dexamethasone 0.5 mg for 7 days and a repeat ultrasound after that. And the primary outcome was the ovulation rate, and secondary outcome ET, number of follicles more than 10 mm, and live birth rate. The results, ovulation rate for letrozole resistant PCO patients who received letroz with DEXA was 30 out of 36, that is 83% of cycles. And live birth rate for each cycle was 17%, with cumulative patient live birth rate of 29%. And they concluded that the addition of dexamethasone to letrozole increases ovulation rates in letroz resistant PCOS patients undergoing ovulation induction. So, glucocorticoids, the use of prednisolone and dexamethasone has been described to increase the success rates of OI in clomiphene-resistant women, and a large-scale randomized control trial with 230 clomiphene-resistant women compared combined treatment of CC with DEXA over days 5 to 14, that is 10 days, against CC and placebo for the same amount of time. In the combined group, 88% of the women had successfully ovulated, whereas only 20% of women ovulated in the control group. And the cumulative pregnancy rate in the combined treatment group was also significantly higher, with 40.5% versus 4.2% in the control group. This is a newer drug which we have started adding recently to the patients with PCOS. Now, effect of berberine in PCOS. In the last decade, botanicals, especially inostols and berberine, administered alone, in combination, or as add-ons to pharmacological therapy, have proven to be effective in the management of women with PCOS. Berberin is an isoquinoline alkaloid that can interfere with the development of PCOS by alleviating insulin resistance, reducing the level of serum androgen, and by regulating lipid metabolism and mild chronic inflammation. However, the good metabolic effects exerted by berberine are limited by its poor oral bioavailability. Many formulative attempts have been made, including those aimed at increasing its solubility, absorption enhancers, lipid based formulations, and formulations targeting lymphatic transport. This article was published in 2023, and this was a controlled, randomized, multicentric, open-labeled clinical trial which assessed the effect of berberine phytosome on reproductive, dermatologic, and metabolic characteristics in women with PCOS. Materials. Enrolled participants were randomly assigned by treating physicians into two groups: the supplemented group, where they received berberine, and the control group in a 1:1 ratio. The berberine group patients received berberine phytosome 550 mg twice daily for 90 days, and the control group no supplement. The outcomes measured were improvement in any of the Rotterdam criteria, and the secondary outcomes were anthropometric measurements, the sex hormone profile, glycemic profile, lipid profile. The results showed that in the berberine group, resumption of regular menstruation happened in 70% of women versus 16% in the control group, which was significant. Normalization of the ovaries anatomy in more than 60% of women in the study group, and improvement of acne in 50% of women versus 16% in the control group, and hirsutism reduction in 14% versus 0% in the control group. So they concluded that the berberine supplementation showed positive effects in women with PCOS and confirmed high safety profile of this nutraceutical. This was study published in India, and they had done a comparative study on the effect of berberine, myoinositol, and metformin in women with PCOS. Um, they had allotted the patients into three groups. The group 1 received berberine hydrochloride 500 mg twice daily. Group 2 received metformin hydrochloride 500 mg twice daily, and group 3 received myoinositol 1000 mg twice daily to compare clinically the clinical parameters, metabolic parameters, hormonal parameters, and lipid parameters before and after 3 months of treatment. So the results showed that between the three groups, berberine showed greater differences in clinical, hormonal, lipid parameters compared to metformin and myoinositol, while myoinositol showed greater improvement in carbohydrate metabolic parameters. And they concluded that berberine may have greater potential to reduce the risk of cardiovascular disease than metformin in PCO patients due to the effect on body composition, lipid profile, and improvement in hormone status. Curcumin. We all know curcumin as our turmeric in our household kitchen. Over the recent years, numerous preclinical and clinical studies have demonstrated that PCO is associated with a chronic inflammatory state, and inflammatory cytokines in PCO patients can induce adipocyte proliferation. Excessive inflammatory factors also produce redundant reactive oxygen species and disrupt internal ROS homeostasis. Thereafter, inhibit insulin signaling and insulin-mediated glucose transport, which aggravates insulin resistance. So, curcumin is a polyphenol derived from the Curcuma longa species and traditionally can be found in Asian food. Recently, this was studied as supportive therapy for a wide range of diseases such as type 2 diabetes, which is one of the complications of PCOS. Based on study on animals, curcumin can be effective in improving insulin sensitivity and decreasing inflammatory marker levels. Moreover, it was reported in a study on humans that the edible intake of curcumin led to a significant decrease in fasting blood sugar, HOMA-IR, HbA1c, triglycerides, and total cholesterol levels in patients with metabolic diseases. So, the therapeutic effect and safety of curcumin in women with PCOS, this was a system ஏன் போயிட்டே இருக்குது இப்போ தெரியுதா? Am I audible? Yeah. Okay. So they concluded that curcumin has beneficial effects on serum markers of inflammation, weight loss, and glucose and lipid metabolism in patients with PCOS. So one more research article on the studying the effect of curcumin on metabolic parameters and androgen levels in women with PCOS. So this was a triple-blinded randomized controlled trial where patients were allocated into two groups, curcumin group and placebo group. The treatment group received two 500 mg edible tablets together at the same time per day for 12 weeks, while control group received placebo tablets similar to curcumin. Biochemical parameters were measured before intervention and then 3 months after intervention. SHBG and testosterone levels were measured 3 months after intervention. Questionnaires regarding the menstrual cycle characteristics and the Ferriman-Galway score were also filled for evaluating hirsutism before and after the intervention. And their results showed that after 12 weeks of intervention, the mean serum fasting blood sugar levels in the curcumin group were significantly lower than the control group, but there was no statistically significant differences between the two groups in terms of triglyceride, cholesterol, HDL, SHBG, and testosterone levels. And they also showed that the amenorrhea and oligomenorrhea frequency became better in the curcumin group. Vitamin D supplementation. The presence of vitamin D receptors in the granulosa cells and the cumulus euphorus cells of humans and animals support the claim that vitamin D plays a significant role in the proper regulation of the female reproductive cycle. Vitamin D receptors and traces of vitamin D metabolizing enzyme were found in syncytial trophoblasts procured from human culturing, and the receptors were also detected in the decidua as well as placenta. Possible mechanisms in the role of vitamin D were protection against oxidative stress and keeping calcium ion levels to maintain the cell's resting potential, which in turn benefits fertilization, cleavage, implantation, and placenta formation. Among PCO patients, they were observed to have lower follicular fluid vitamin D levels, and findings suggest that vitamin D may have an indirect impact on the diagnosis of PCO through its effect on AMH levels. And this connection between AMH and vitamin D as a vital substance for proper follicular genesis was seen when vitamin D treatment decreased serum AMH levels in PCO patients. In addition to decreasing serum AMH levels, vitamin D therapy also increased serum anti-inflammatory soluble receptors and increase the levels of progesterone, estrone, and estrogen in the blood, and increase the levels of estrogen and progesterone in the human placenta. And it was also noted that vitamin D decreased the serum testosterone level while increasing insulin sensitivity. This was a study which analyzed the effect of vitamin D supplementation on ovulation and pregnancy in women with PCO. The objective was to evaluate the effect of vitamin D supplementation on pregnancy and ovulation. Online PubMed, Medline, Embase, Cochrane Central Register for Control Trial search was done online, and the results showed that the results they had analyzed 20 randomized control studies with 1961 subjects, and pregnancy rate, ovulation rate, mature oocyte number, the rate of vitamin D supplementation group were significantly higher than in the control group, and early miscarriage rate, androgen levels, LH hormone levels, FSH hormone, and premature delivery rate were declining significantly than the controls, and no notable differences in the biochemical pregnancy rate, gestational hypertension rate, gestational diabetes mellitus rate, fertilization rate, cleavage rate, and high quality embryo rate was seen. They concluded that vitamin D supplementation contribute to the higher pregnancy and ovulation rates and lower androgen, LH, FSH, and early miscarriage rates in women with PCOS, regardless of the use of ovulation induction drugs or assisted reproductive technologies. This article assessed the effect of vitamin D on pregnancy in women with PCO. It was a retrospective and prospective. It included both retrospective and prospective studies. It involved 200 patients with PCO and 200 healthy women. The prospective study included 160 patients with PCO receiving vitamin D or placebo supplementation, and pregnancy rates were assessed after a maximum of 3 cycles of ovulation induction, and serum concentration of 25 hydroxycalciferol, LH-FSH, progesterone, estradiol, testosterone, and fasting insulin, LH-FSH ratio, and BMI were evaluated. And in the retrospective study, patients with PCO had lower 25-OD3 concentrations than healthy women, and pregnant patients with PCO had higher 25-OHD3 concentration than non-pregnant women with PCO. And the pregnancy rate was lower in the vitamin D deficient group compared with the non-vitamin D deficient group. And in the prospective study, compared with placebo supplementation, vitamin D supplementation increased the serum concentration of 25-OHD3 and reduced the LH-FSH ratio and concentrations of LH and testosterone significantly. After ovulation induction, the pregnancy rate was higher in patients in the vitamin D supplementation group compared with the placebo group. And they concluded that vitamin D deficiency is common in patients with PCO, and vitamin D deficient patients with PCO have lower pregnancy rates after ovulation induction compared with non-vitamin D deficient patients with PCO. And supplementation can improve the pregnancy rate and mitigate basic hormone disorders. Therefore, monitoring vitamin D supplementation and checking the concentration before and during interventions are essential for patients with PCO. Case scenario: Mrs. Y, 26 years, married since 4 years, who had come to us with primary infertility and irregular menstrual cycles. She was a known case of PCO and hypothyroidism. Previously, she had 3 failed ovulation induction cycle, 3 failed IUI cycles outside. The male factor was normal, AMH was 5.8. At A4, when she had come with the patient's request, she was proceeded with the ART. ANTAC protocol was used, and injection Gonalef 225, Menopur 75 were given for 10 days, and she was triggered with dual trigger, Ovitel and Decapeptyl. A retrieved number of oocytes were 29, and the mature oocytes were 18. 15 of them fertilized, but unfortunately, no viable embryo was formed. She was counseled for thorough evaluation, and the gene femina panel was sent. Gene femina panel consists of analyzing a panel of genes that are related to female infertility, where they give an input on suggestions and inputs on the ART protocols and the dosing, and suggestions on donor oocytes and all. So the report revealed favorable LH stimulation profile and highlighted factors impacting her reproductive outcomes, such as idiopathic female infertility and dysregulated immune responses. And these findings guided subsequent treatment modifications, emphasizing the importance of personalized care. In following that, she proceeded with the ovulation induction cycle and IUI cycle, one each, and they both failed. She then decided for second stimulation cycle, and this time agonist protocol was used, and pretreatment with injection lupride and ocipil were given, followed by stimulation with Gonalef 225 and Pergoveris 150. She was triggered with Ovitel, and 35 oocytes were retrieved, out of which 27 were mature and 24 fertilized. She had 7 day 5 embryos and 3 day 6 embryos. Out of that, 2 good grade day 5 embryos were selected for frozen embryo transfer in the subsequent cycle. Following that, the patient achieved in this challenging case. Thank you. Stop share.
Yeah. Hello.
Yes, ma'am.
Yeah. Any questions? I couldn't see any questions. Yes. Thank you, Dr. Satyapriya and Nitya. Any questions are there? You can also ask, unmute yourself and ask, I think. Satyapriya, you can tell me which do you prefer? Letrozole starting at 5 mg for a patient. If not follicles are formed, then you go for 7.5, or you want to do the next cycle 7.5 mg.
We have to decide based on her previous cycles also and the response to previous cycles. So I generally start them on 5 mg and then increase the doses subsequently within the same cycle.
Oh. In the same cycle, you wanted to increase it to from 5 mg to 7.5 mg.
7.5 for 5 days, but I've not done the extended regimen till now.
Okay. Maybe we should all do a proper study on these three protocols and see which ways it is getting affected.
Yes, ma'am.
Any experience on tamoxifen for thin endometrium patients with PCOD? Dr. Nitya? I think you would have tried.
Hello.
I think for thin endometrium, yeah.
Yes, ma'am.
For thin endometrium
Yes.
and no follicle which is forming resistant PCOD, what is the experience on tamoxifen for ovulation induction?
Not much for ovulation induction, ma'am. We don't prefer tamoxifen as a first line,
Okay.
or even in resistant cases,
Okay.
unless in an HRT cycle.
HRT, I think we are using a lot, but there are a good number of studies on thin endometrium patients with PCOD. We can try tamoxifen because it has a dual role of stimulating the ovaries and also having a good endometrium. Anyway, we should try that and see. Adjuvants that you believe in, practical use for PCOD. Dr. Satyapriya and then Dr. Nitya also. You can share the screen and talk. Yeah. Yeah. Okay.
Generally, when the patient comes, they're already been started on insulin sensitizers outside. But the newer drugs are showing promise because we've been using berberine with inositol last few months here at A4, and my exposure has come only after coming here to these. And I think there is no harm in using tablet curcumin and berberine.
Yes, I think the patients are also happy using just curcumin, and these patients, maybe the high testosterone is that you want to use something extra for these patients. If there's a hirsutism and they're resistant, you feel that they're not having a good ovulation.
DEXA
Also helps. I think metformin also helps to reduce androgen levels to an extent.
Yes, ma'am.
Okay. So, good. Are you still wanting to do laparoscopic ovarian drilling to any of the patients?
No, ma'am.
No, ma'am, no.
Anybody wants to do? For example, you're posting a patient for a tubal block. Will you do a laparoscopic ovarian drilling or not?
Ma'am, we'll have to explain to the patient if she's a lean PCO
Yeah.
with no other known infertility factors, and probably counsel the patient for ovarian drilling. But just the number of punctures and keeping
kept up.
energies and kept in mind, not just charring the ovaries.
Yes. So when a patient is having polycystic ovaries and you wanted to do a laparoscopy for some other indication, then definitely if the AMH is more than 6.8 or so and thin PCOS, there is advantage. Considering that we should not be cauterizing the ovary too much. Well said. So any suggestions on how to use gonadotropins for PCOD patients?
So, ma'am, on PCOS patients, so the problem is that it takes some time for it to get recruited. Once it recruits, it comes as a big bunch. So, not to go for a very high dose, probably start with a low dose. But at the same time, how much this chronic low dose patients are going to be compliant, and I don't know if they'll have the patients to take injections for 14 days or 21 days when we are going to stick on to our protocols and the books. But however, seeing their previous reports and previous stimulation will give us a fair idea on what we can do and improve the success for ovulation. I feel getting an ovulation itself in PCOS patient will be the first point of success.
Yeah.
And so only looking at their previous follicular monitoring chart, we'll fairly have an idea. So if it is usually a FSH, then we will definitely go with a 37.5 unless the patient is having a BMI of more than 30. Otherwise, if it is HMG, then probably a 75 should be okay.
Yes, well said. So we should start with the low dose. Maybe what we generally do is 37.5 for 5 days. So 5 days of therapy with 37.5, if the recruitment is not there and the follicles are all less than 10 millimeters, then we can hike it by another 37.5. So maybe 5 days should be kept as a cutoff, though even with 37.5, we have seen OHSS patients. So response to letrozole itself has to be assessed. The baseline stromal index and the Doppler parameters are very useful, at least for patients whom we are thinking that they can have hyperstimulation or previous resistant ovary, then we can look into it. Because I think in a everyday practice to do Doppler on a baseline scan is going to take another 10 minutes. So maybe we should start doing at least for patients who are resistant and we are going to start gonadotropins. Those patients we can do a baseline stromal index and then do. We would like you both to have another session on Doppler and follicular monitoring. Anyway, thank you for the exhaustive presentation. I think we should do more work on PCOD. Any other questions is there? Otherwise, we'll close the topic. I would like to invite our doctors for SOFC program on 15th and 16th. Whoever has joined, 15th and 16th of February, we are having Dr. Nirmala Jaishankar being the president, having a SOFC program being happening. And we also have ultrasound workshop conducted by Oxycon on February 22nd. The registration is just 2,000 rupees. Kindly, it is available. The registration is available by put up in the Oxy groups. So if anybody is interested in fertility ultrasound, yeah, kindly come up and join. Kindly join. We are happy to have you. Any suggestions for the upcoming FOG webinars? Kindly post it. That will also be useful. Thank you for your.
Thank you, ma'am.
Thank you, ma'am.